Welcome, everybody, to our session on building internal PHA capacity for cross-sector partnerships. I'm Kelly McElwain, and I'm a research analyst with the Public and Affordable Housing Research Corporation. And today you'll also be hearing from my colleague, Keely Stater, also at Park, and Kyle Hanson and Alyssa Erickson of the Minneapolis Public Housing Authority, and Sylvia Blanco and Rodolfo Rodriguez of the Housing Authority of the City of Austin, and their partner Freya Spielberg with the University of Texas at Austin. So today, our session is going to begin by giving an overview of what we know about Housing Authority health initiatives. And this is based on a survey conducted by Park and CLAFA last year among housing authorities and what initiatives they were engaged in. We're then going to hear from housing authorities themselves on their experiences and advice on building capacity. And then we're going to close out with a Q&A. So overall, we find that from our survey that half of housing authorities are engaged in some type of health initiative. And most of these initiatives rely heavily on partnerships. 91% of housing authorities engaged in these health initiatives have some type of partnership in place to support at least some of their initiatives. And by health initiatives, we mean programs, policies, or services that provide medical treatment or care for the public or focus on disease prevention. We find that these partnerships vary in formality by size. However, most housing authorities don't have dedicated health staff to support these partnerships. So they rely heavily on resident services or other staff within their organization to maintain these partnerships. So when we look at the types of health initiatives housing authorities are engaged in, we find that primarily they're targeting preventative health. About 3/4 of housing authorities engaged in health initiatives target preventative health. And over half are also targeting medical health conditions and substance use disorders. And about 1/4 are targeting behavioral health conditions and physical disabilities. And as I mentioned before, their housing authorities heavily rely on partnerships to support their health initiatives. However, less than half have formalized agreements in place to support these partnerships. So overall, we find that the most common type of formalized agreement in place we see are memorandums of understanding and followed by referral agreements. And then a few housing authorities are also engaged in data sharing agreements, shared funding, and shared staffing. Oh, and also with the differences in partnerships, we also see partnerships formalities. We also see that there's some differences in terms of like how many housing authorities are engaged in these partnerships by their size, where some larger housing authorities are, in terms of number of units served, are formalizing their partnerships at higher rates. And then when we look at the types of organizations housing authorities are partnered with, we see that they're working with a really wide variety of health organizations. About 3/4 are working with partnerships, are working with community-based health providers like home health agencies and public health departments like their local health department. And over half are also working with healthcare providers like their local hospital and Medicaid managed care organization. And then about 1/4 are also working with advocacy, funding, research, and community development organizations. We also asked both housing authorities that are engaged in health initiatives and those that do not currently provide health initiatives what barriers they face to both providing the services altogether and expanding these services. And we find that lack of funding and lack of staffing are the two most commonly reported barriers reported by both housing authorities with and without health initiatives. And we also see that lack of resident interest is another less common barrier, and mission creep or health initiatives being outside of the Housing Authority mission, and lack of partner interest as more minor barriers. So I'm going to pass it off to my colleague Keely Stater, who is the Director of Research and Industry Intelligence with the Public and Affordable Housing Research Corporation, or PARC, to talk about what our next steps for understanding Housing Authority partnerships is.
Great. Thank you, Kelly. So as Kelly said, we did this research with CLAFA last year, and we found some really interesting results that Kelly just shared with you. But we wanted to dig a little deeper and really understand some of the issues of capacity that might be going on at PHAs, and really try to get a picture of the evolution of these partnerships and how they were able to deepen their effectiveness. Some of our preliminary research in the survey and some of the work that we've been reading are identifying things like community support, funding, of course, support from leadership, dedicated staff, as key elements of capacity that move partnerships forward. But we really wanted to know, how does this happen? How do you build capacity internally? What's the story? Are there any clear patterns that we're seeing at PHAs? So we decided to do more research. And this time what we're doing, and we've just started this research, so I'm going to tell you a little bit about what we've learned and what we plan to do. Our qualitative interviews with PHAs to try to really delve into how did they manage this process, and how did they really build these partnerships, and what were the key elements that were able to lead to effective partnerships. And we also want to know, were there any catalysts, anything really external or internal that impacted these partnerships? So we were going to continue our interviews, and hopefully we'll be able to release some of our findings in the fall, and potentially a toolkit for PHAs. But some of the things that we've found interesting so far when we talk with PHAs about how they really leverage their resources to build capacity for partnerships, some of the things we've been hearing are things like selecting partners with shared clients or shared goals, including program outcomes in strategic goals, so making health one of the housing agency's primary goals or resident outcomes, embedding support for these initiatives into their administrative processes. So if you're able to add a few questions at intake or at various touch points with residents to really embed these into processes that already exist. Aligning activities with organizational and staff incentive systems, so staff kind of see the reward for doing the extra work it takes to build these partnerships, and informing decisions with data, and including data-driven checkpoints. And I would add also, we've been hearing about changing the culture of the staff at the PHA, and really making resident outcomes and partnerships a focus of what they do there. So these are some of the things we've been learning about growing strong partnerships, and we're excited to continue this research and maybe talk to some of you in the room about what you're doing, and hopefully share with you our findings in the fall. And with that, I'm going to turn it over to Minneapolis to tell us a little bit more about what they're doing and what they've been finding in their work.
Great. Well, good afternoon, everybody. I'm Kyle Hanson. I'm the Director of HCV and Human Services for Minneapolis Public Housing Authority. Just a quick question. I'm curious, how many of you in the room are here at this summit for the first time? All right. So by the end of this couple of days, you're going to go back to your organizations with all kinds of new ideas and concepts. You're going to be really excited, and you're going to go back and go, where can we find the money? Where can we find the staff? How can we do this? We're already overburdened. But I tell you what, Alyssa and I came to this conference last year for the first time, and it doesn't take as long as you think to start putting the pieces of the puzzle together. You have lots of peers in these rooms, so make connections, get business cards, and start to identify your files, because you're going to walk out of here really energized and excited to go back and do some work in your community. So with that, we're going to talk about 4 main areas today. We're going to talk about strategic vision. We're going to talk about the importance of research. We're going to talk about how to seek out partnerships. And we're going to talk about that all-important obtaining resources for the work that you do. At Minneapolis, we found that it was really important to start at the top and work with our board, work with our executive leadership team to identify a strategic vision and plan. So the bullets that you see on the screen are actually right out of Minneapolis Public Housing Authority's strategic plan. Housing preservation and creation, which involves RAD and working on that conversion. And then right there you see education, employment, and health. It's been identified and approved by the board of directors as one of our strategies and one of the top 3 things that we want to work on as an entity. And then operational excellence. So once you have a strategic vision identified and your own important issues listed, it's time to talk with residents and community and engage them in the conversation. Talk to staff about them seeing value in the work that you are doing and planning on, because this is a new way of thinking. It's no longer the day when a housing authority can just do the work of handing out a Section 8 voucher or housing a bricks and mortar public housing building, because we all know that there is much more that's needed for that. So these partnerships and vision are needed if we're going to move forward in a successful way. So articulating a strategic vision, it's important to identify your own priorities and needs in your own community. You're going to get lots of ideas over the next couple days about some programs that are working in other communities. And we decided to concentrate on education and health as a starting point. And this really gave us the freedom to explore these areas in depth. And the goal for our education programs was to create new housing voucher type programs for students experiencing homelessness and to strengthen partnerships with community nonprofits for families. Alyssa's going to talk a little bit about our health strategies.
Thank you. My name is Alyssa Erickson, and my role is Director of Research with Minneapolis Public Housing Authority. And the reason I'm really involved with the health approach is that it's been very research-driven, data-driven. So we started with wanting to know more about what's currently happening. We have a lot of partners, especially in the high-rises, but we didn't really know what their collective impact was in the lives of residents. So we're still in the process of trying to learn more about that. And then we wanted to reestablish a human services program. That was something that the Housing Authority had in the past and was cut during a time of budget cuts. But now we really feel the urgency of having, like Kyle was saying, more than just property management in the high-rises and for all people that we're serving. Then we wanted to work on establishing more partnerships. So providing supportive services and getting the money needed to do that is something we're going to talk more about.
Great. So some of our inspiration for education programming actually came from Tacoma, Washington's work on their education program with their elementary school. And I can tell you that once you know of programs, we actually just called Tacoma and talked to them, and they sent us templates and agreements. So we had a real easy starting point because we didn't have to start everything from scratch. We were able to work with that and then fit it to our own local needs. But it's important, as you're identifying these strategies and partners, to really dig down into the data and find out what are the needs of the communities, what has worked at other places. There's all kinds of research components and studies that have been done. So use that information. And what we found in exploring this education program was that there was a gap between the HUD definition of homelessness and the McKinney-Vento definition of homelessness. So those couch hopping folks that didn't really qualify for some of the funding, but were really having an impact on the schools. The schools came to us and said, you know, we have families on these in our schools that are couch hopping, and that we find that they're the ones who have academic problems and attendance issues because they never know where they're going to be from one day to the next. So in designing this program, we used that information to use the McKinney-Vento definition of homelessness to fit the housing subsidy that we are providing for our Stable Homes, Stable Schools program.
And with respect to health, we started with hiring consultants to do a landscape assessment of the current service providers, specifically in the high-rises. They did interviews with all the partners and with residents and property managers, and one of their recommendations was for the Housing Authority to play a greater role in coordinating partners, because they felt that there were gaps, there were people who could be not receiving the services they needed because some services are only at certain buildings, but that's not necessarily the buildings that need that service, because it was in many ways ad hoc when an organization came to us and said, we want to work with your high-rise residents at this building. We would say, okay, great, but without really knowing, is that what the people in that building need? So right now, we're continuing to develop that strategy and figure out how to coordinate between the partners and match the needs to the services. And to understand the needs better, we've been working on data matching with Medicaid claims data. And in this also, we're following in the footsteps of King County Housing Authority and Seattle Housing Authority, who did an extensive data match with their public health department in King County. We have struggled to find the data partner that wants to do this match with us. That's been one of our challenges. We started off working through our county, but encountered a lot of roadblocks in terms of the level of information they were willing to provide to us. They wouldn't tell us anything at the building level. They only wanted to give us big aggregates, like we can tell you about everybody that you're serving, but we manage at the building level. So that was really critical for us. And they also were not willing to share any information about diagnoses or conditions. So our new data partner that is more mission aligned and working with us is the City of Minneapolis Health Department. So they have a team of epidemiologists who have the ability to get to the same Medicaid claims data, and we're just beginning the conversations with them about how that'll work. And just this week, I had an exciting meeting with them and learned about a new data source that they have access to right now that I think will be able to tell us a lot, and that is the death records. Because in our high-rises, death is the #1 reason for people exiting housing. And I didn't know this, but the epidemiologist told me that on the death record, you have not only the cause of death, but you have other conditions that the person had at the time of their death. So that is a really good data source for us to learn. Maybe they died of one thing, but at the same time, you know, they had diabetes or they had these other things. So that'll give us a more insight into what's happening with people's health in the high-rises. And we're really looking forward to learning more.
So as you think about staffing needs early on for your program, it's really, I can't stress how important it is to make that commitment to having someone who knows how to do analysis, who knows how to work with data, and because it can really drive your programs forward, and there's so much information out there to obtain. So the next area is seeking new partners and strengthening existing relationships. An example of what we did in Minneapolis, we have what's called the Stable Homes, Stable Schools program. We reached out to the city and kind of pitched a program to them. And the city is now investing in dollars directly into housing subsidy. So we are doing a 60-40 split with the city. The city is putting up 60% of the dollars for housing subsidy. We're putting up 40%. The city is also paying for a service component and for help for the families. We formed partnerships with the YMCA, the City of Minneapolis, Minneapolis Public Schools, and Hennepin County for this particular program.
And on the health side, as I mentioned, we have a lot of partners. So you can see quite a number of logos here. And these are the organizations that we want to do a better job of coordinating and also giving them avenues to coordinate with each other. So right now, there's no mechanism for referrals, and organizations are working with the residents that they identify, but they have no way to know, oh, I could recommend that this person also work with this other organization who's here, because they don't know like who else is active in the high-rises. There's no structure around that. One of the most significant programs that we're trying to support is an effort through Volunteers of America, which is a social service provider we've contracted with for 40 years to work in the high-rises. They established a community health worker program last year based on work they were doing and needs identified by residents. But they've really struggled to sustain that program because the Medicaid reimbursements are not enough for the community health workers alone. So we're working on figuring out what would be a sustainable funding mechanism to keep those community health workers going. And the other issue they've struggled with is integration to the primary care system, because they're not able to get referrals from primary care doctors. So if we can get something set up that would like function as a hub where primary care doctors working with someone who they feel could use assistance following up on, taking their meds or doing whatever it is that they need to do, they would be able to refer them to the VOA community health workers who would then continue to support them.
And finally, how do you pay for it all, right? That's the big question in the room for everybody. Obtaining resources is the second area that really needs focus for your agency. Somebody or a department dedicated to working on grants, to seeking out grants, to looking through things for grants, because it's not something that housing authorities are used to doing. Our money comes from HUD, and it is kind of a new area for us to seek out other sources of funding. And initially, some of the funders also are surprised when you're at the table asking for grant money. But we have found that once we start to explain what it is that other housing authorities are doing, that we have been really successful in obtaining grant monies from them. Just a couple of examples. The City of Minneapolis, the program we talked about, $3.3 million a year for the Stable Homes Program. Another grant we received was from the POLAD Foundation for $500,000, and that is to provide homeless prevention funds for people who are facing an eviction to pay back rent or utility bills.
In the same schools through the Stable Homes, Stable Schools. It's just 15 schools in the Minneapolis School District. All right, we need to wrap up. On the health side, we've received a very helpful mentorship through Data Across Sectors for Health, DASH, and the All-In. It's a national network if you're not already connected to them. They have a ton of resources in their website. And then the community health worker program I mentioned, they got a grant that'll take them through the end of the year. But after that, we're concerned about their ongoing sustainability because they already had one cycle where a grant ended and they had to cut back the hours to 0.2 FTE. Ended up losing those staff because nobody can make that work. Then they have to rehire new community health workers who have to build new relationships, and we don't want to see them continue to go through that cycle. So we are currently applying for other grants that would support the Housing Authority in developing our health strategy and also support those community health workers.
Great. Just one last comment as we're wrapping up. So a year ago when Alyssa and I came to this summit, we left here full of these ideas. And a lot of the things that we're talking about were not in place a year ago. So don't go back and think that this is something that is going to take 5 or 10 or 15 years. If you start to put those pieces together, they can fall into place pretty quickly, especially once you start to identify some of those funding sources to help you hire additional staff or do the research for you. So, thank you.
Good afternoon, everyone. My name is Sylvia Blanco. I'm the Chief Operating Officer for the Housing Authority of the City of Austin. And so I want to say a lot of what Minneapolis is doing. I think we're doing a lot of similar things. But in terms of Austin, so we recognize, and everyone in the room knows that housing is the safety net. It's a critical safety net. But to truly improve lives, we know it has to go beyond the bricks and mortar. And so within our agency, we have established what we call the 3 pillars of success. The first pillar is under youth educational success. The second pillar is for adult workforce development. And the third is health and wellness. And for many years, we really built up the first 2. We had a lot of great partnerships in the community to help further the youth piece and the workforce development piece, and we really didn't quite have the resources or the capacity to build on the third pillar. And so what we did have the opportunity to do is reach out to Dell Medical School through the University of Texas at Austin, and we began a dialogue. It was a brand new medical school, the first in Austin. And so we really started to talk how we could sort of join forces in helping the health outcomes for our families. And around that time, actually, there was the opportunity of a planning grant through CLAFA and CSH, and also underwritten by Robert Wood Johnson. And so through that planning grant opportunity, we also made the commitment to match dollar for dollar those grant funds. And it was a $40,000 grant opportunity, so we were able to double its effect and impact. And what we did was, since we had the roadmap that we had established on how we were wanting to build up our health and wellness piece, we knew that we needed to have someone drive it, and that was going to be their sole focus, was health and wellness initiatives. And so that's what we did. We used those dollars to bring on board a contractor. And through that role, we ensured that it had the visibility that it needed by placing it within our executive department. And in fact, that role actually reports to me. And so it has that visibility and the access to the executive team. And that really makes a huge difference. And so, again, it was quickly evident that by making that person dedicated solely to driving the health and wellness narrative and strengthening our strategic partnerships for HACA, it was the right decision to make. And in 10 short months, we decided to actually create an FTE, which is our first director of health and wellness ecosystem, which is Rodolfo. And so this position is empowered to lead HACA's strategy, while aligning support across all levels, meaning residents, staff, our commissioners, our executive team. And actually, based on a 2018 survey that Kelly has pointed to, we knew that HACA was also in the minority in terms of having staff dedicated solely to health and wellness initiatives. And so, as I mentioned, one of our, and I think that's one of the slides. Is it this one? There we go. So only 13% of large housing authorities have dedicated housing and health staff. But again, it made all the difference in the world. And so, as I mentioned, one of our key partners in HACA's health strategy is the Dell Medical School and Dr. Freya Spielberg. So at this time, I'd like to actually turn it over to Dr. Spielberg, and she'll share more about Dell Med and highlight some of her work with HACA to date. Thank you.
Thanks. Good afternoon. So I'm Freya Spielberg. I'm an associate professor at Dell Medical School in Austin. I'm a family medicine physician, and I'm a health service innovation researcher, and have been at Dell just a year. As Sylvia mentioned, it's a brand new medical school. In fact, it's the first new medical school that's being built from the ground up at a academic research institution in the past 50 years. It just doesn't happen that often. And what's very interesting about Dell Medical School is their main mission is to improve the health of the community and to revolutionize the way people get healthy and stay healthy. And because of that, we understand that 80% of health is what happens outside of the healthcare system. And so most of our work is in collaboration with community partners. We were fortunate enough to find the Housing Authority of the City of Austin pretty early, and as Sylvia said, started having these conversations, and we quickly realized that the partnership was synergistic in that, the Housing Authority had a mission to improve the health of their residents and build capacity. Dell has a mission to translate research into action. And we both bring very different skill sets, but together in a very short time, we've already been able to accomplish quite a bit. We started with this needs assessment, and we were able to bring good survey methodology to it, and also both a lens to look at sort of the needs and preferences of the community, but also the needs of individuals. So we were able to survey over 500 residents and reach over 70% of individuals in each of 3 different housing projects, which is a really high survey completion rate. And that was because of the relationships that HACA has developed with the residents. So that was a very successful collaboration, and we learned a lot about what the residents needed, and we found, similar to your finding, half the residents had been to the ER in the past year, and about half had not had primary care. We found that over 70% in each domain that we surveyed, and we looked at preventive healthcare needs, chronic disease management needs, mental health needs, behavioral risks, and social determinants. Over 70% in each of those domains had one or more needs. And we found that with each additional need in each domain, an individual was more likely to have gone to the emergency room. So now we are working on addressing those needs with a next grant that we received. And I'm going to turn it over to Rodolfo to start talking about the health strategy.
Definitely. So I think one of the things that I love about our partnership and one of our strongest partnerships is actually with our residents. We start there. Like Dr. Freya mentioned, we created a survey that could take up to an hour to complete. And I usually start off by asking, when's the last time your landlord asked you about your health? And usually no one raises their hand. But it just goes to show the level of trust HACA has built and maintained with residents, because knocking on someone's door and opening up about your health, it's really private. So to be able to reach 70% of the adults in 3 communities was pretty spectacular. I also think it also shows that residents have a strong interest. But there were a lot of things that we did learn, and it's influenced our co-design strategy. So First and foremost, HACA's approach in partnership with Dell Med is to listen to residents. Though only 70%, not only, though 70% participated, the other 30% declined or at least knew about the survey. And that's kind of a big deal when you talk about outreach. The other thing is now that we have data, we understand that each site, so HACA oversees a portfolio of 18 communities. Each site has its own differences, solutions, and personalities. So we're not generalizing that data and applying it across. We are pretty intentional about any community we step foot on. We will do outreach, listen to those residents, and let those residents design the solutions to their own health. Through this survey, based off of the urgency and because you have to start somewhere, we did start with adults, and we reached also our senior residents. However, we are intentionally trying to aim towards achieving whole family health, meaning including residents under 18, so children, youth, adolescents. That'll be fun. It'll challenge us to be interactive and to engage them. So, there's also a balance about, health is really broad. That's what I love about the partnership. And if I was to sum up that community health needs assessment, the needs are complex and diverse, so you need creative funding and dynamic partnerships to be able to address those. And there's always a conversation, and it's always ongoing, about the impact. Do you want to go deep or wide? If you go deep in one community, are you neglecting the other ones? And so I think we all sort of feel those pressure points at some point. And I think part of the combining forces is we do offer our own set of talents, and we look at each opportunity and decide when to co-lead, when Dell Med leads one and we support, and the other way around. So I'll go a little bit more into that into this next slide. So we are being very intentional about seeking transformation and turning away transaction. There's a difference between the two. We assess each opportunity and invitation to partner very carefully, and we look at that and look at the community needs and make sure they align. 9 out of 10, they don't. This applies, when I say partnerships, this applies community partners. This also applies funding opportunities. And so let me give you an example of what transformative partnerships look like for the Housing Authority at the City of Austin. That takes me a lot of time, so I'll be saying HACA going forward. One of the examples is Dell Medical School. Besides bringing talent at the organizational level, we're very intentional about making sure that staff meets at all levels. In January, we actually had a roundtable discussion with the leadership. We had the Vice Dean of Health Ecosystem for Dell Med School at present, the Chair of Population Health, Dr. Freya, the evaluator team, and we also had sort of our versions on the Housing Authority side in terms of leadership. We also have a partnership with United Healthcare, which a session after this one, we'll talk a little bit more about where we've done intensive data sharing so we can learn about the needs so about the health needs of mutually serving members. We also have a partnership with Community Care, which is the largest federally qualified health center system in Austin. They serve members in Austin that are medically under or uninsured. Through our CHNA, we found out that about half of them consider Community Care their medical home. So we were already in discussions with them prior to knowing this, but this really just solidifies that there's so many strategic opportunities to align. In fact, one of the 18 communities and one of the 3 that we did survey, this community, Chalmers Courts, is 8 blocks away from downtown Austin, east of downtown Austin, and is undergoing complete neighborhood revitalization. Buildings will go down, new ones will come up, density will happen, more access to affordable housing. And what we are intentionally doing is preserving 2 existing units so that we can open up with community care, primary care, behavioral health, and dental services on site. Now, in terms of funding, I know sometimes we could all, if there's an opportunity that feels close enough, we might be tempted to go after it, but given the fact that I've been a one-person capacity, I've been very careful with how I spend my time. We were very fortunate that at the local level, a local health foundation known as St. David's Foundation put out an RFP for Health Starts at Home. This was an experimental grant of theirs. They've never really funded health at home type of interventions. So they were very open to allowing the community to come up with their own solutions. This was very perfect for us because we looked at our CHNA, and though the needs were complex and diverse, there were two bright spots that stood out to us. Residents desired a need for navigation support around health and healthcare and social services. Close to 90% of them actually desired that. I think it was a little bit over 85% that desired on-site group visits with local health experts to be able to talk about any chronic health disease that they have and manage it, as an example. Those two things developed a program called Bringing Health Home and allowed us to secure the largest philanthropic grant that HACA has received in its 80 years of existence. On a national level, we're pursuing another opportunity that's more infrastructure focused, but this is an example that Dell Med would lead because of their expertise, where it would allow us to custom design a digital platform that will help prioritize residents that are most at risk of ER use or hospitalization, and improve staff workflow and automated evaluation. One thing that I forgot to mention on the St. David's grant and the Bringing Health Home is that we were also able to bring on board 2 community health workers, or promotoras, and we were very intentional about connecting and investing in public housing residents to fill those roles, which is the sort of the origins of the roles. And we can talk a little bit more about that in the Q&A if you'd like. And so now, not only is there 1 housing staff person, there's actually 4 for the Housing Authority, which is pretty great. An example about an opportunity that we went after was actually through Dell Medical School, where they partnered with a local state health foundation that was doing an RFP for, it was a very specific focus. We thought if our data, we have strong data, let's go after it. We got feedback, and we just learned, though we were invited to make it to the next round and apply to the, submit a full application, we realized that it was a priority for us to develop infrastructure organically and expand internal capacity, and some of the guidance that we got wouldn't allow us to do that. So we decided it was premature and withdrew our application. Yep, actually, I yield my time. No, I'm just kidding. That's kind of all I have. Good job, team.
Well, thank you, everyone. It's very exciting to hear about what you're doing. We just have a couple of questions up here, and then we'll turn it over to the audience for Q&A. The first question is, a lot of housing authorities starting out have very limited resources to engage in these partnerships, and we were just wondering, how do you get the most out of limited resources? What strategies do you use, or what elements of internal capacity are most critical to kind of getting the biggest bang for your buck when you're starting out?
I'll take a stab at that one. So what we did in terms of bringing health home, we had the privilege of having a Jobs Plus grant and also a family self-sufficiency program. And so we leveraged the staff time and resources, and also connections to residents who have already made the commitment to go after certain goals to improve their self-sufficiency. And so it was already a built-in network that we were able to tap into. And that was actually our way of identifying our community health workers, our resident community health workers. They were Jobs Plus and FSS participants who we had already noted that they had completed medical assistant and CNA training. And so it was an easy fit. We had a great list of eligible candidates that we could work with. And so those were some of the ways that we've been able to leverage some of those capacities that have been built into our organization.
With respect to research and the data matching we've done, we have focused on the high-rises because those addresses are public information, and so did not require a data sharing agreement, because I think a data sharing agreement can be a huge drain of resources and time. So that we focused on getting as much as we can, just address matching. So like looking at the death certificates, they're just going to look at addresses, and that allows us to learn a lot without going through the lawyers and getting bogged down in a data sharing agreement.
I think, too, it's important to focus on those partnerships. And sometimes it's about knocking on the door and inviting yourself to the table. Because oftentimes the housing authority is not the first group that people will think of if they're having a health strategy meeting. But it's important to figure out what's going on in your community, and especially when you're applying for grants, to kind of give up some of that power in that and allow a partnership grant application. Sometimes some of the nonprofits have very strong grant writing experience, and they may even have a full-time grant writer. So it's okay to really focus on those partnerships and allow for some of the structures that are already in place to do some of the work for you.
Can I add? For us, it's been a big learning curve, learning the health space. You know, we're just not familiar with everything, the language, everything. So the mentorship that we got through DASH was really helpful. And speaking of knocking on the door and inviting yourself in, they recommended that we find out what our county public health department was doing with their CHIP process. And we said, what is the CHIP process? So it's the Community Health Improvement Plan. We had never heard of it, never been part of it or connected to it in any way. So I got a name and invited myself to the meeting, and lo and behold, found out that their #1 public health issue that they were working on for Hennepin County was housing stability. But yet they had not talked to us at all.
We're only the biggest landlord in town.
So speaking of partnerships, we found in our survey that almost half of PHAs had some type of partnership. What steps or approaches have you found to be most successful in growing those partnerships from kind of the just kind of coincidental partnerships to something stronger and more effective and deep?
I would say, starting with the initial meetings where rather than coming in with a plan, you really brainstorm together and find the areas of synergy, and that kind of sets the stage so you know where you want to go if you have funding. And then, as always, funding opportunities are a great way to evolve the relationship, because as you're working on the grant together and planning it, the pieces fall into place. So those are, I think, 2 important steps.
Okay, do you mind if I add something to that? Of funding partnerships, something that I forgot to mention was, there are also institutional differences, and it's important to acknowledge that. We have had many healthy conversations and pressures and points, right? But it's true. But we do recognize that the power of combined forces is greater, because we recognize from the Housing Authority side that that survey we designed would never have been as robust. But I'd like to believe that DellMed also, we wouldn't have achieved that 70% participation. I think we had originally said, 30% will be fine. I'm like, well, that's not representative. So it's understanding that, but those conversations when it comes to funding allowed us to think about vision and use of those funds, because something that I've learned is if I was to throw out the word research, it means something very different to the housing sector and academia. And so a lot of it has also been put our money where our mouth is, like the Housing Authority before I even came deciding to match a planning grant. And even going after this first grant that we did secure, DellMed saying, we'll match some of our research time to demonstrate. And that's something you don't come across often, right? So, yeah.
One of the other things I think early on that I did in my department was talk to the Community Action Partnership in our town. And they have all of the resources that our participants on the HCV program are needing or looked for. Energy assistance, food assistance, financial literacy training, all of those things. And they were actually saying, we're really having trouble connecting to folks in Minneapolis. And I said, well, I've got about 5,400 participants for you to meet. And for the cost of a desk, in my department, they now have a person that comes in a few days a week. From time to time, they'll come to a briefing. When we have new participants that we hear of that have an issue, we can walk them right over to the desk and say, here's someone who can help. And there's a link right there. It didn't cost anything to form that partnership. And it's been of great value to them because suddenly they're able to also meet their numbers.
I can just add one more thing. As we all collectively look for ways to fund certain programs and services, it's important to establish the relationships way ahead of those grant opportunities, especially when they're looking for cross-sector partnerships, because if you're doing it as a reaction to a grant opportunity, it's not genuine, and it's essentially just not going to be a very effective proposal. So just having the relationship of, just information sharing. It may not necessarily translate to services right off the bat, but you have that foot in the door. You start to create that relationship, and once that opportunity does arise, you at least have that established partnership and relationship that you can speak to. So I just wanted to add that piece as well.
And that is exactly what I wanted to say. In our education, yes, I'll just give an example. In our education work, we really benefited from having started to build the relationships. Our executive director had met with the superintendent and talked about how we could align efforts. And then Kyle had reached out to a specific school that he saw in a news feature. And the principal is this really inspiring leader. And so he wanted to pilot an effort similar to Tacoma's, just focused on that one school. And so he had already been working on this concept and starting to develop a program. And essentially, I'd like to say it was a shovel-ready program opportunity, where then we had our new mayor looking for an investment in housing. And he talked to one of his staff, who was one of our board members, to see what ideas there were out there that could really make an impact on children experiencing homelessness. And so that became the program that is now Stable Homes, Stable Schools. It went from the one school 15 voucher idea to now it's going to be up to 300 families served, because the city was looking for it and we had the shovel-ready idea.
Well, thank you, everyone, on our panel. We'd like to open it up for questions.
Hi, good afternoon. I'm Marcia Smith from the City of San Diego. Thank you all for blowing my mind, so thanks. Rodolfo, can you talk a little bit about the survey and the 70.2%? How many of those families were there, and how did they answer for the children or represent children in that?
Okay, can you repeat that last part?
How did you represent children in your survey group, because you had mentioned that there were 504 adults?
That's an easy one. We did not reach out to children. So 0% of that is children. Adults, because we needed to start somewhere. And it's a little challenging with children, but that's where we're headed towards next, where we would need consent from the adults. And it was just a way for us to start somewhere. In terms of how we reached that 70%, so we leveraged some internal staff and invited some community partners that could benefit from having access to data like this, including Dell and a few other partners that had a presence at those 3 sites. We put together a one-day training on how to administer a more sophisticated survey, and we basically trained folks. We also did leverage the planning grant to have $10 incentives to gift cards, so at least you have that. And we also were able to reach residents that speak English, Spanish, Vietnamese, Arabic, Chinese, Korean, American Sign Language and Spanish American Sign Language. The reason why we were able to achieve that is we were knocking on doors and realized once we had reached that wave, we switched times, and we also had an online version of the survey for working families that didn't want to open their doors. And there were actual times where I was able to talk to 10 residents that declined, trying to find out why that was, and I was able to change a few hearts, maybe 3. And it was just good for me to understand that though 70% was an unprecedented level at HACA to achieve, we still sort of have a responsibility to try to build trust with the others. As far as youth, I guess maybe hopefully next year if we're invited, we'll have a story to share about that. So, yeah.
And I want to add just one bit to that question. In another project that I did going door to door in an affordable housing community, we did ask for the person who completed the survey to complete surveys on behalf of their children. And so it's possible, to do that and to collect data on the whole family. It's just, it's how much resource you have, and, do you want to go wide or deep? And so in this case, we're really looking forward to adapting the whole survey and getting additional funding so that we can focus on kids specifically.
Hi there. Interestingly enough, Kyle, I just received an email from our community action group saying they had extra money and did I have any participants who might be interested in it. So anyways, my name is Irma. I'm with the Housing Authority of Maricopa County, and my question is, I'm interested in hearing your strategies for outreach to rental assistance recipients versus housing communities.
I think that's an area we're still working on. We have not done any data matching, as I mentioned, because those are private data, the addresses. So we have not worked on that at all with the health strategy. With education, it's going to be new families who are participating in stable homes, stable schools. So we really haven't done much with current voucher holders yet.
And I would say we haven't reached out to the voucher holders yet. However, if we can all work together and help financial reform come about so that community health workers can be reimbursed for their time, then it will be a fairly simple proposition to expand the community health workforce and have them go to the properties to do the assessments and wellness activities.
I do want to point out it's a little more challenging, so it's not that we're not thinking about that. It's so for our data sharing agreement with United Healthcare, we shared very basic social demographic data of everyone that lives at a HACA property but is also in the voucher program. So it's about 25,000 individuals. And of the 25,000, a very small percentage, and I can't say the number because I can end up in jail. No, a very small percentage, HIPAA, right? We learned a very small percentage in the entire portfolio. We have data if they live in our portfolio, but also are with United Healthcare. And it's really hard for us to, the data sharing agreement do make it really hard to know who and how to dedicate resources. It's a lot more challenging, but we're hoping that once we do have an understanding of how to impact health on the housing side, that's at some point we could reach that. But we do, it's more of a strategic move for us to focus on housing communities, because any service we bring, we know where folks are at. We're meeting them where they're at. So,
can I make one more comment related to the data and the challenge of getting data and a strategy that we are engaging in at Dell Medical? It is very difficult to get individual level data from a lot of entities. However, if you have a health information exchange, and if the community health workers have a consent that they sign, when you do the initial needs assessment, then you can tap into the health information exchange data to get hospital data, electronic health record data, and that's really the direction, I think, of the future for most communities. We did not have a very robust health information exchange, and that's a challenge in a lot of communities. Who's going to pay for it? Who's going to manage it? And you really need a Switzerland, kind of a neutral party, to do that. And so Dell Medical has taken on that role and is now kind of an aggregator of data, and that will, create the governing processes so that different community entities that can use the data to do something to improve community health will have access to it. So that's.
Hello. So first, I just wanted to congratulate everybody. I really am enjoying the presentation. I think the message of coming to the conference one year and getting a whole bunch of ideas and then kind of returning, kind of to deliver some of the fruit on that. And I also just wanted to congratulate Rodolfo, because you have the coolest job title.
Yeah.
Just thought that was really great.
Yeah, I improve health at the expense of my own. No, I'm just
That's the tagline.
So, and my question, though, was going to be for Minneapolis. So in the face of all of these different needs, you touched a little on this in your presentation, that you came up with a plan and it was approved by the board. So how did you think about that? How did you operationalize putting together a plan? I find that we're very often just responding in an ad hoc way. There's an opportunity, so we sort of go in that direction. How did you come up with, how did you do a plan, and then how did you prioritize?
Yeah, so I guess about 2.5 years ago, our executive director, who's sitting over here, Greg Russ, joined us. He came from Cambridge. And prior to that, we had had the same executive director for an extended period of time. So there was a new opportunity when Greg came in, and we actually had a board retreat for a couple of days off-site. We had some facilitators come in, so there was a neutral party there, and really just had the discussions around what is possible, what priorities does the board have, what are they interested in, here are some things that are working at other places. And through those conversations, over the 2-day period, we were able to really hone in on what that strategic vision and plan was, and then did the legwork of kind of putting it to paper, reconvening with them, and they passed it at their board meeting as a official document. So it did take some time and effort, but it was really about taking that time off-site and really talking about potential and possibilities. And I think we'd be happy to share with you who we used for facilitation with that if you'd follow up with us after too.
I manage the FSS program and I work with Jobs Plus. And when I go out to housing authorities, I think that there's historically a perception that for supportive services, housing authorities have to go to the community with a handout and they're very like, will you please come and do something for me? But actually housing authorities have an incredible amount of data and information and relationships, and so really bring a value add to the table. And so thank you for just sort of giving wonderful examples of how that works, and that's something that I would love to be able to kind of spread to folks. My question, though, is in the very, very beginning, you said that 70% of housing authorities have a health initiative, and that number really surprised me. And I was wondering, is that like of the 3,300 housing authorities in the country? And if so, who is managing those initiatives at the housing authorities? I was just really surprised.
I think the number is 50%, and yeah, which is still high, And I think we had about 300 respondents. We did send the survey out to all PHAs in the country. Even those without email addresses, there are a few of those still left. So we did send out to everyone. We had about 300 respondents, so the 50% would be of the 300 respondents. And we did adjust the sample to correct for size a little bit. So this is an adjusted sample to kind of reflect the population of PHAs. So we do think it is pretty representative, even though we had a smaller sample size. But yeah, it's still a great number, about half. We don't really know who was managing. We did not ask that question. I don't even think we asked what staff members were involved in the partnerships. We just asked if you had dedicated staff. And we did ask about staff hours, didn't we? How much did we ask? No? Next survey, we'll be asking about staff hours. But that's a great question, and that's some of what we hope to learn in our new, more qualitative aspect was kind of who's involved and how does that matter to your effectiveness.
That would be super helpful to know, because one of the responses we get very, very often is we don't have the staff capacity, and obviously you spoke to that as well. But if we could have more information about folks who might be on a smaller standard staff who are managing these relationships, that would be really helpful to share.
And I think to answer your question again about like the high percentage of housing authorities engaged in these initiatives, it could also come down to how we define health initiatives altogether. So we included initiatives like policies, programs, and services that promote healthy lifestyles. So that can be anything from like food and nutrition assistance programs, and which a lot of housing authorities are engaged in. So health initiatives is really broad and can include a lot of different things like smoke-free, implementing that. So,
and I think the largest category of activity was general wellness, which again can be, we have an exercise class once a week for our seniors or something like that. So they're really, to Kelly's point, a large breadth that we're capturing.
Just to add a little to that, though, some of my colleagues, they express a huge learning curve also because they don't have a health background or training. So that's also something to consider.
One thing to piggyback on that in terms of health initiatives, as you know, we had to go smoke-free. So I imagine that a lot of maybe some of those health initiatives was around smoke cessation, and that probably also opened up some other conversations to bring in maybe some general wellness activities. So that's another food for thought.
Hi, my name is Kim. I'm from United Way of Greater Atlanta. I'm a little groggy from allergy medication, so I hope this comes out clear. I echo a lot of what's been said in the room and commend you guys for really integrating health into your work, and health is housing, vice versa. I was curious, we're doing a lot of work in Atlanta around the social determinants of health, and I noticed, particularly with community health workers, so we're doing a lot of work in that space, and also trying to sustain through reimbursable models in Atlanta. I noticed in terms of the partnerships on the slide that there were FQHCs and community health centers. I didn't necessarily see hospital systems. Is that a part of the work that you're doing in terms of partnerships, particularly as there is a lot of work happening as it relates to value-based care? So I would encourage you guys to continue your partnership in that space, and also encourage you to connect with your local United Ways if you haven't done so already. They can be a great intermediary in terms of connecting other partners. You guys have done a great job in that space, but I noticed that in terms of capacity and not, being in the space of healthcare, sometimes it can be difficult. And lastly, part of what we try to do is establish public-private partnerships in terms of funding. So local United Ways, depending on what their focus is, can also help facilitate some of those public-private partnerships, which can be very helpful as a funder, but also as a thought partner in that space. And so I'd like to hear from you guys if y'all are doing that?
So from our perspective, we are beginning to work with the county medical center, which would be the main hospital hub for many of our folks to visit when they have an emergency. And it's in the early stages of development with them, but they're very interested because clearly the cost to them of the multiple ambulance visits and high health needs of our folks is a real burden on their system. And as far as other healthcare providers or hospitals, we're in the beginning stages of exploring that. And through Alyssa's team and her work with some of our data partners, we actually now have data do we have it by building or just by AMP? So we have it by asset management projects. So we know of these certain buildings, there have been X amount of ambulance visits, and we're trying to dig down even further into that data to find out what were those visits for, what was the frequency, and then that's a pretty powerful tool to take to United Healthcare or for us it's UCare or some other entity and say, look, we have thousands of your folks here on your plan, and they're 3 times as likely to head to the emergency room. How can you help us out? That's a pretty strong pitch. So we're in the process of preparing for that pitch, but we haven't gotten there yet.
Yeah, and one of our goals will be to get the support of the insurance plans, the Medicaid MCOs. I think they should pay for the community health workers.
Absolutely.
Okay, so that's what we want to get them to do, but we have to figure out how to get there. So we've had one conversation with UCare. We're going to have a meeting coming up. They're the largest MCO that Medicaid recipients are enrolled in the high rises. And then we have to reach out to the others as well.
Yeah. Just to respond from our work in Austin, there's a couple ways that we're working with the hospitals. One is just on the data sharing piece. Ideally, our community health workers will get a ping when one of our residents shows up at the ER or the hospital so that they can support the transitions to other care and hopefully prevent future ER visits. So that's one way. I think the discussions around, the benefit of these programs to the hospital, to the MCOs are ongoing. What I've found in my discussions with some of the MCOs in the past is they have a large population that have not been to primary care, and it's, their mandate. They're going to get financially penalized if those clients don't get into primary care. So they've approached not the Austin group, but another group that I have been working with in housing to take on those clients and to send community health workers to the homes to help link them to wellness visits, and in other places we've tried telemedicine for that. So I think there's a lot of ongoing conversations, and it's really figuring out how to change the policies and help the managed care organizations and Medicaid locally take the leap, trust the data, and put resources into funding community health worker support.
We have time for 2 more questions.
Hi, I was curious, you had mentioned talking about evaluating the collective impact of partners on site and strengthening your coordination of partners on site. How specifically are you doing that?
We don't know yet.
When you know, I'm sure a lot of us would. I think that's a huge challenge and something that's great to really focus in on. So,
yes, that's what we'd like to figure out as we work on developing our health strategy.
So one thing regarding coordinating partners, an idea that we've been discussing in different groups. Probably most of you are aware of Aunt Bertha, which if you're not, just go to auntbertha.com and you can put in a zip code and it will give you referrals for any kind of social service need and health need. So one of the things that we're doing, at the beginning of our project is really trying to develop those relationships, identify the prioritized referral providers for each type of need, and then we'll give those to Aunt Bertha and say, update your records, make sure those pop up first. So that'll be a tool for the community health workers to use. And then what ideally, it'd be lovely to be able to have information on whether your residents completed the referrals, and Aunt Bertha has a system in place to do that as well. And of course, it's just a matter of getting the funding to localize it for your needs. But those are the kind of things that are going on now.
What was the name of our website?
Aunt Bertha, so AUNT, Bertha, BERTHA, it's either .com or .org.
I'm not sure.
Aunt Bertha, I think maybe .com.
My name's Leah Greenwood. I'm with the Vancouver Housing Authority. And it sounded like a lot of the partnerships you were talking about were more traditional health care, medical care. The biggest gap that we're seeing is mental health and behavioral health. So I was interested in hearing both from the standpoint of when you're asking those questions of residents, which generally they're less willing to share information about mental health, or behavioral health or addiction. One, what were strategies to get that information, and then what sort of partnerships have you developed?
Sure, I'll take it. Is it okay if I start? Yeah. So actually, part of the 30% that we didn't reach were folks that were not able to fully represent themselves. So some of the mental health statistics, we take them at the minimum. There were Actually, mental health was one of the things that came up as a top issue. So there were folks that felt comfortable enough. I would say we do feel very confident about the data that was self-reported. The one thing that did actually stand out to us was the underreporting of substance abuse. And that's kind of maybe something where we have a zero drug tolerance, so maybe they felt like, I don't want to tell you that. So consent form, yeah. So, but all that to say, though, we have partnered with the mental health authority known as Integral Care in Austin. They serve our residents with mental and emotional illnesses. And so we're trying to be more intentional about the kind of outcomes we can achieve together. But it's kind of, it's only been 10 months, but there's still a lot, they're a key partner in our work. So.
And I just wanted to add one point about the question and how you assess mental health. So there's standardized, validated instruments. There's a 2-question PHQ-2 that if people answer positive for that, then you do a longer 9-question assessment that is to help diagnose mental health issues, depression. What we found is that if we ask patients how often they're experiencing stress, we had a higher percentage of people who reported experiencing stress greater than half the days in the week. It was like 33% compared to like 22% who screened positive on the PHQ-2. And I thought that was a really good question to identify those folks that might need additional support and maybe prevent a serious depression or anxiety disorder in the future. So
we're out of time, but that is definitely a gap that we've identified and that residents have prioritized is more services for behavioral health.
Great. Well, thank you all for coming. It's been a great conversation.